Good morning, ladies and gentlemen. My name is Stephen Genuis, and I'm very grateful to have the opportunity and the privilege to share a few ideas with you this morning. I'm very grateful to Thomas for inviting me to share some thoughts on this issue. I really appreciated the legal presentation. It was wonderful. I'd like to come at this from a little bit of a different perspective, from a clinical medical perspective, and to talk about freedom of conscience in clinical medicine. What I'd like to do is to give a little bit of background on the issue. I want to talk about what I believe are the origins of the conscience denial. I want to talk about healthcare and contemporary culture, and then how might we respond, those of us who are clinicians. My friends, as we all know, for those practicing medicine, we have expanding technology. Sometimes it's hard to keep up with all the new technology that's coming out. We have a vast array of options and procedures. And now with the removal of the Hippocratic Oath, we no longer have a consistent fundamental ethic within medicine. And thus, clinical practice has become an ethical minefield in many areas and many specialties, right? So, with diversity and no longer a common vision in society about what is good, of course, challenges arise when the ethics of individual health providers collide with the dictates of patients, authorities, or institutional committees. Furthermore, it's interesting to observe over the last 80 years that there has been a significant shift in the role of physicians in terms of clinical expectations. Many years ago, physicians were considered to be authorities in medical matters. They diagnosed and treated illness. But around the 60s, with the decline of the centrality of religious faith and fewer people seeking advice from religious sources, the MDs, physicians, increasingly began to adopt what has been described as a priestly role. The World Health Organization, came out with this idea that health is a physical, emotional, social, and spiritual issue, not only physical, and that MDs were tasked with securing holistic well-being, and so they adopted this sort of biopsychosocial spiritual model, and all of a sudden they were making moral and ethical and social judgments for patients. But now, over the last 10 to 20 years, we've had another shift in terms of clinical expectations under the label of patient-centered reform, so that now physicians are to become service providers to fulfill patient requirements. So the emerging construct now of the contemporary health professional is one of a values-neutral educator and a technician. The educator, who's supposed to secure awareness of options and autonomous choice for patients, and then the technician, in that we are responsible for carrying out the wishes of these autonomous patients. So doctor-patient relationships now have increasingly been reduced to an exchange of goods and services. And the MD task is less about caring for patients' health as much as serving clients' informed choices. But you combine that with the escalating array of choices and values-neutral providers, who decides then what's acceptable and what is right and wrong? So the ethical framework then in clinical practice means that clinical decisions are ethically informed only by patient choice and what is legal. And of course, what's legal and the overall ethical directions then are decided by those in power, right? So the current situation is that the powers that be have determined that human choice is ethically more valuable than human life. But this is in direct collision fundamentally for followers of Christ, where individual human life is sacred, and that some choices are considered wrong, perhaps even sinful. How did we get here? I'd like to give a little bit of background. As we all know, the work of Hippocrates was foundational to ethical practice in medicine. Hippocrates, born around 460 BC in Greek island, he learned medicine from his father and his grandfather, who were physicians and spiritual leaders of the time. And let me say that I've read a lot of books and papers and about Hippocrates, and there's a lot of differences in historical reporting and interpretation, and it's sometimes hard to discern accuracy. You know, I've read things that he never really existed, that it's all a myth in the first place, to that he was leader of a temple, cult. So I've tried to glean information as much as I can that is consistent. And what it appears is that at that time, around 460 BC, the prevailing paradigm in their culture was that illness was the outworking of evil spirits and vengeful gods, this metaphysical etiology of illness. And the cure for affliction at that time was often chemical potions, where they were given for purging and emesis to release the spirits or to appease them. But Hippocrates was a critical thinker, and he observed that potions of bribed medical practitioners were frequently being used to poison business and political rivals. Hippocrates also observed that rather than these metaphysical factors in terms of causation of illness, that there appeared to be definable determinants associated with the development of illness consistently. That there were, he recognized innate diversity between constitution and subsequent health. So he talked about inborn determinants, about nutritional determinants. The way people ate had a difference in health. He described environmental determinants, where people worked, the kind of occupations they had, different areas of the country, and so on. And so in response to his observations, Hippocrates endeavored to introduce rational thinking into clinical practice. So he rejected this paranormal causation of illness and rejected such potions as a treatment for disease. Okay? And in the clinical domain, he pioneered the fundamental thesis that every disease has a natural cause. And he surmised that if you find the cause, then perhaps you can cure the disease. And in terms of his treatment, his therapeutic approach, rather than potions, he had an enormous respect for nature, and he talked about working with the inner physician to facilitate healing. In the ethical domain, Hippocrates endeavored to introduce a template for ethical behavior in medical practice. He was concerned, of course, by the corrupt behaviors of the day, and so him and his followers put this body of work together called the Hippocratic Corpus, so that in the clinical domain, he challenged the prevailing paradigm of illness, and in the ethical domain, he formulated the Hippocratic Oath, which was one part of the Hippocratic Corpus. For his enormous contributions to the practice of scientific and ethical health care, he was awarded with the title of the Father of Modern Medicine, right? In the ethical domain, the oath and variations on it, depending on the cultures, became the principal code of conduct, ethical conduct for physicians for over 2 millennia. And in that oath, there are 4 fundamental pillars. One, that MDs are accountable to transcendent authority. Number 2, that human life is sacred at any stage from conception unto natural death. 3, that we are not to do harm, only to do good. And finally, that MDs are to have a virtuous character. But in the latter part of the 20th century, we had a silent revolution in medical ethics, and we had this marked metamorphosis. And the Hippocratic Oath was quietly sidelined. Why? First, the 4 pillars were challenged on all fronts. Okay? The idea that MDs are accountable to transcendent authority. Well, of course, with the secularization of society and the mindset that it's time to get religion out of health care, and the removal of spirituality from medical practice corporately and personally for most, this had to go. This idea, of course, that human life is sacred with expanding abortion and now physician-assisted death, this had to go too. Number 3, not to do harm, Well, that wasn't the focus anymore. Under the idea of autonomy and choice and the professional ethic that even if you might consider it harmful, you can't impose your belief. This was no longer a priority. And for the idea of having a virtuous character, again, no longer a priority, with the idea that we must leave our values at the door in the provision of medical care, that we are publicly funded service providers, and that care is to be focused around patient choice, not our individual virtue. So, the Hippocratic Oath then was removed as the ethical standard, this immutable bedrock of medical ethics. It was abandoned as a pledge by med students, became increasingly irrelevant morally and culturally, okay? And for some, it remained sort of as a symbol of professional cohesion, but not much else. But not only was it abandoned, over the years, it has increasingly become the symbol of derision and scorn. At the U of A, where I work, John Dossiter, who's a professor, and who was subsequently appointed as the ethicist for the Canadian Medical Association Journal, wrote a book called Beyond the Hippocratic Oath, where he condemns the paternalism of the Hippocratic tradition. And one of the fundamental books used in most medical faculties around the world is a book by Beauchamp and Childress, where they, again, condemn the paternalism of the Hippocratic tradition. The anti-Hippocratic sentiment has continued. And here, one of the leading experts in medical ethics in the UK recently spoke at a conference saying that doctors who refuse to break their oath are evil. So, my friends, over the span of a few years, we have rapidly come from swearing by the Hippocratic Oath to being asked to defy it. So what's replaced it? So now we have these codes that are prepared by regulatory committees and bodies, right? There's no longer a universal ethic. It's subject to change depending on the governing ideology. It's applied by ethics committees at individual institutions. It's enforced by the colleges of physicians and surgeons and hospital administrations. And if we violate the current flavor, then we're subject to discipline. And what are the pillars of these modern codes, my friends? The new ones are tolerance, autonomy, professionalism, non-paternalism, that are diffused throughout academia and inculcated into the minds and hearts of students at medical schools. Now, one could spend a long time critiquing these, but these new pillars, the definitions are dynamic, and they mean completely different things to different people. For example, if we look at the word tolerance and intolerance, honest disagreement with a patient regarding an issue, you could be labeled as intolerant and then paternalistic, right? And so the reality is that it can be interpreted in all kinds of different ways, and these can be used as a club to hammer those who dissent. So, if we look then over the last number of years, we had Hippocratic medical ethics, but we had increasing secularization of society and academia. Contemporary medicine or bioethics was introduced. The Hippocratic Oath was removed. And thus we've had subsequent legalization of abortion, increasing mainstream acceptance of physician-assisted death, and now we have freedom of conscience endangered. Now, what has this looked like on the ground? I've been involved in interviews for medical students at the University of Alberta for those people trying to get into the Faculty of Medicine. And about a dozen years ago, having done it for many years, you don't have to retrain every year, but about a dozen years ago, we were all required, if we wanted to continue this, to go and have retraining on how to be an interviewer. And at that time, they were very explicit with us about the kind of student that we want and the kind of medical student that we don't want. And so they enacted this role play, and they brought out a medical student who was playing the person, and she was pretending to be a very young teen requesting oral contraception without parental knowledge. And then they had one interviewee who came in and was very supportive and they called that professional behavior. And then they talked about the kind of student we don't want. And that student are those who would have personal, moral, or religious opposition to legal medical care and who are not willing to go along with patient requests. So now we are being asked to consider this concept of professionalism, and the clear message was those whose ethical compass renders them unable to dissociate their own values from patient care are unsuitable for medical practice, and they are to be turfed. Okay? Then, over the years, the last number of years, just general interaction with med students, doing electives and stuff like that, I began to observe that there's mounting pressure to conform, particularly in reproductive and sexuality issues. I remember one of the Canadian Physicians for Life conferences that we had for med students, a student talked about being threatened with failure and expulsion for conscience refusal, just on an oral exam question. It began to creep more and more into the medical literature. I'll quote from the Journal of Society of Obstetrics and Gynecology of Canada, quote, "Physicians who feel entitled to subordinate their patients' desire for well-being to the service of their own personal morality or conscience should not practice clinical medicine," unquote. Was this coming from medical practitioners? No. Of course, it was coming from people outside the medical community, in this situation, some lawyers. We began to see the ethical question, ethicists getting into the game. And here we have Julian Savulescu writing in the British Medical Journal, "The doctors who conscientiously refuse to perform legal procedures are offering medical services and are not fulfilling their obligation to care for patients." Now, what do doctors think about all this stuff, considering that they're the ones that people are talking about? Well, in academic medicine, major publication asking physicians, close to 80% said that a physician should never do what he or she believes is morally wrong, no matter what experts say. But despite what the physicians believe, the portrayal by groups outside the profession, again, from ethicists, some lawyers, and so on, that they presented conscientious objectors as denying patients access to legal and scientific health care, with the accusation that they are unprofessional, unethical, that they're subordinating science to their misguided morality, and that they're not respecting patient autonomy. So in 2008, the Ontario Human Rights Commission gets into the game, and they say that essentially it was their position that doctors must essentially check their personal views at the door in providing medical care, with the suggestion that it perhaps might be a human rights violation to refuse care based on conscience. Then it got into the political realm, and in Alberta, where I live, this was brought up and became an election issue, where the government clearly came out and said that they oppose the right of health professionals to exercise their conscience, that physicians should be required to fulfill responsibilities regardless of their conscience, right? And this, of course, culminated this year with the Ontario College of Physicians and Surgeons requiring that doctors refer, or in some cases perform, procedures that might be against their conscience. Now, they state that their objective here is to secure access to care for patients. And they indicate that those who choose to limit the health services they provide for reasons of conscience or religion may impede access to care. So again, they state that their objective in doing all this, their reason, is to secure access to care for patients. Now, when I read this, it didn't make any sense to me, practically as a physician. I thought, what? This is counterproductive, right? If you ask me to make a referral to somebody because I don't want to prescribe the pill or whatever, right? Okay, I tell my office staff calls somebody else's office, they arrange a referral, which may be, 4 or 5 weeks away. They then go to see that person, so that's what would typically happen in a referral, right? Well, the patient could go right across the street to a walk-in clinic, right? So if they're now requiring a referral, it's exactly the opposite. It delays access to services, right? And abortion clinics, they don't require referral. And they say, well, what about, people out in the country? Well, the college or the government could easily set up a central number for accessing services, right? And telehealth could be used. So demanding referral from specific MDs delivers the opposite of what they claim to want, which is the rapid provision of services, right? The second thing is that enforcing this policy is going to diminish access to service overall, because it's going to drive away a number of physicians and restrict practices of a lot of primary care docs where we're short already. So it's going to diminish access to overall care. So this is doing the opposite of what they claim to want, right? Thirdly, it doesn't make any sense. It's defying their stated objectives. Human rights commissions are supposed to be talking about more tolerance, heralding choice, and proclaiming respect for diversity. This policy, of course, displays supreme intolerance for diverse views, individual autonomy of physicians, and choice. Didn't make sense at any level to me. And so I began to question, maybe this isn't about patient care at all. Okay? And so I began to ask, okay, well, this is under the guise of conscience. Is it really about conscience? Well, they're saying that, exercising your conscience is a bad thing when we're talking about issues like abortion or contraception or assisted death. But a few years ago in Quebec, there were women who were going for virginity certificates, right? And a lot of physicians, based on conscience, were refusing. And they were hailed as, wonderful physicians, that this was excellent, right? And of course, we have physicians working overseas in other countries that may have different values. And if they're working in a country where female circumcision may be acceptable and the norm, if somebody was to come to them and say, can you do this, even though it was legal and the patient was requesting it, for them to refuse, they would be hailed as good based on conscience. So I thought, maybe this isn't about conscience, because it appears to be selectively targeting specific issues of importance to a specific group of physicians. Right? And then I thought, okay, what about autonomy and choice? Well, patients are supposed to have autonomy and choice about abortion and oral and some other issues. Maybe autonomy, we're not supposed to go for it. Again, with the virginity certificates, even though patients came asking for this, no, we weren't supposed to allow them choice. We were to refuse them. Recently there was an article in the Post about patients who now think that they're trans-abled, right? They're fully abled people who believe that they're actually disabled. And so they're asking for physicians to have their limbs removed, right? Well, we don't allow patient autonomy or choice in these matters. There's many, I could go on, issues of, gender identity, all kinds of things where we're restricting what patients want regardless. So maybe it isn't about autonomy either. I also began to observe the incredible disproportionate intimidation against physicians who would even question this, with increased surveillance clinically in all kinds of ways, threats of discipline, and the horrendous media against a small handful of sincere MDs. And I was reminded in Proverbs that he who is following the right way is detestable to those on the wrong way. So, my friends, I began to ask, what's this actually all about? Are regulatory bodies trying to drive out doctors who espouse a Christian worldview? Is that what this is about? And are regulatory bodies intent on preventing young people with Christian worldviews from entering the medical profession? Because as Sean Murphy has pointed out, that, medical students must display a preparedness for to do what they believe is wrong or unethical or evil, now is a prerequisite professional responsibility to join the medical community, right? Now, and how do they do this? Very easily. A few weeks ago, there was interviews for med school, and they have this procedure called MMIs, or multiple medical interviews, and they have, 8 or 10 different stations. And what happens is they then present them with a scenario, and they ask how would they respond. So, often they'll have, 2 of the 8 stations, for example, where they'll give a difficult ethical situation where you have to respond. And if you don't respond appropriately, I'm sorry, you're not in. Okay? So, my friends, what's this actually all about? And I want to talk a little bit about the origins of conscience denial. As I began to try to explore where this is all coming from, going from one thing to another, it came back to something that was written at the beginnings of Christianity in a document called the Didache. That is Greek for teaching. That was written about AD 40 to 80. That was a foundational document in Christian faith, and it's said to be the teaching of the Lord to the Gentiles by the 12 apostles. And the themes in this Didache it was a summary of the basic instruction about the Christian life. And it was a foundational discussion of Christian ethics. It was translated in 1884 into English. And the very beginnings of the document start out, and they talk about the 2 ways. And there's explicit discussion of the fundamental paradigm of the world. And they say that there are 2 ways, one of life and one of death. And there is a great difference between these 2 ways. And it contrasts the behavior and choices that lead to life and those that lead to death. So they explicitly talk about abortion and infanticide, murder, sexual promiscuity, advocating for such behavior. But one that really caught my mind is that of being double-minded as the way of death. Because what's happening now is one of the pressures and tactics that's occurring now for medical students and for clinicians who have personal objections is that they're suggesting that they have a personal conscience and a professional conscience. So, in your personal life, you can believe whatever you want to believe and execute that. But in your professional life has a conscience according to the profession, so that you are to be double-minded. In modern times, this Didache theme had reemergence from Pope John Paul II at World Youth Day in 1993, where he talked about the way of life and the need for God's people, the church, to further a culture of life. And in 1995, he released a document, an encyclical entitled Evangelium Vitae, or Gospel of Life. And so we see this reappearance of the two ways theme, where there's discussion of the escalating struggle between the culture of life and the increasing culture of death in our society. But 2 points of particular note in the encyclical were with relation to the culture of death, were the components of the culture of death, and secondly, the enablers of the culture of death. There was discussion about, in terms of components, crimes against life. And here you see, again, which was initially published in the Didache, abortion, euthanasia, participation in willful self-destruction. But another component of the culture of death where they talk about are assaults to integrity, which is attempts to coerce the will, or a denial of conscience. And it explicitly states, and I'll quote, that these things and others like them are infamies indeed. They are a supreme dishonor to the Creator. But when they talk about enablers of the culture of death, it's very sad. There's discussion in the document, and then a world that is becoming increasingly post-Christian. New forms of attacks on the dignity of the human being will be opened up by scientific and technological progress. And what is an amazing prophecy. And that under the name of autonomy, these crimes against life will be done with the free assistance, the assistance of healthcare systems. So where are we today, my friends? Well, I would suggest to you that this battle over conscience rights is a current permutation in the struggle between the way of life and the way of death. And I want to explore this question. Is it true, what it says in the document, that healthcare systems are advancing a culture of death? My dear friends, in healthcare, there's many wonderful, godly, and good people who are giving, incredible life-giving care. Many people in this room are doing that every day, but I'm going to suggest respectfully that some aspects of our healthcare system are indeed furthering a culture of life. We could talk about reproductive technology, where millions of human embryos are being created, destroyed, frozen, manipulated, trashed, and that between 85 and 90% of embryos now are being wasted. We have eugenics now with routine prenatal screening, with the elimination of the imperfect, widespread abortion. Millions have been eliminated. Physician-assisted death is increasing. And it's not stopping anytime soon, right? There's a new procedure, if I had time I would discuss it at length, called NIPT. And NIPT is where it's now a prenatal screening test where they just take maternal serum in the first trimester, because what's been found is that placental cells, as they get old, reflecting fetal DNA, that they break down, the DNA gets into the maternal circulation for excretion, so that just by a maternal blood test they can get fetal DNA and do genetic testing, so they can test for trisomy with a simple blood test now. But as many people know, this is basically a search and destroy mission, right? And as Will Johnson has said, that basically it's putting the child on probation, right? But now in genetics, we have what's called microarray testing, where simultaneously you can test for all kinds of genes, right? And you can test, well, does this child have a BRCA1 gene, so may be predisposed to breast cancer? Do they have this gene that may predispose them, to autism, or this gene that predisposes them to this? So within a few years, they'll be able to have a whole array, so a printout for a woman at, 8 weeks, showing, okay, well, your child has all these genes. Well, maybe you should consider terminating because your child is at risk. You can imagine the incredible pressure on parents, and people will be told it's a responsible thing to do, and society can't afford to have these kind of children. And at the other end of life, of course, despite the fact that only 30% of patients have had access to palliative care in this country, and there hasn't been any rush to address it, the minute that they talk about allowing, physician-assisted death, the medical schools are jumping in, right, with curriculum to develop this right away. So how should I function then in a system that in many ways is promoting a culture of death? How, as an individual physician, how should we respond, or how can we respond? Basically, there are two options: surrender or stand with conscience. I will tell you, as I've talked to some of my colleagues in administration, and that the assumption is people will cave, that most people will cave, right? It's just assumed that that's what will happen. I want to, my last section here, just go through this, surrender. So it's essentially becoming personally involved despite going against conscience. In other words, succumbing to patient or administration requests. And what are the consequences of this? And it's difficult to measure, right? It's not something that you can measure easily. But there are some papers in the medical literature which look at this in terms of the effect of surrender on the individual doctor, on patients, and on society as a whole. So one of the emerging ideas of that is of moral injury, okay? And to define this, it's the consequences resulting from perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs or expectations. And what kinds of moral injuries? Well, Alison McIntyre talks about the impact on character, that encouraging physicians and other professionals to separate themselves and their values for the roles they perform is a formula for the dissolution of virtue. The impact on their ethics. And, Farr Curlin writes in the New England Journal of Medicine that acting conscientiously is the heart of ethical life, and to the extent that physicians give that up, they're no longer acting as moral agents. Because to act ethically is to do what one believes is right. To participate in what one believes is wrong is to act unethically and to relinquish integrity. And of course, there's the concept of moral residue. And that's been defined as that which each of us carries with us from those times in our lives when, in the face of moral distress, we have seriously compromised ourselves or allowed ourselves to be compromised, and consequences of shame and the impact on physician well-being, on morale, on self-perception, and on our spirituality. The consequences are not insignificant to us as people. What about patients? Okay. Well, the whole physician-patient relationship is based on patients' trust that we're committed to their best interests. And as it was written in the medical literature, that patients will not be well served by moral automatons who shape their practices to the dictates of whatever regime is currently in power. And, participating in decisions considered to be harmful or detrimental sets a dangerous precedent that predisposes the physician to facilitate future decisions that are suboptimal. Of course, the impact on society, one doesn't have to look too far, in South Africa or a Nazi regime where the society at large is at risk when physicians collectively become subservient to the ethical whims of whatever regime is in power. But what about surrender by referral? If we look at physician-assisted death, for example, what is the objective of a referral? An ethical physician refers to consultants who they determine will undertake interventions deemed to benefit. We don't refer to people who we think are going to harm our patients. We refer, that's basically what a consultation is. So to knowingly carry out a consultation to another practitioner who will proceed in a way that the primary doc feels is damaging or harmful defeats the objective of consultation. It's an oxymoron. It makes one complicit in harm, and it enables acts that transgresses personal moral belief. And for those who have taken the Hippocratic Oath with regards to physician death or abortion, a current translation of the oath says, "I will not counsel with direct intent to end a human life." Well, arguably, counseling and arranging for a patient to go to another MD precisely to induce death violates this fundamental aspect of the oath, right? And the other option is to stand with conscience, to continue to practice based on personal integrity, to refuse to act against your conscience, okay? Collectively, what does that mean? Well, there are incredible efforts now to rewrite the ship, to challenge legally, to educate the public, political efforts. These are important and godly efforts to advance the right way. Some people talk about building a new ship, the development of a parallel medical society with restoration of foundational Hippocratic principles to establish a charter and an oath. Of course, this requires a lot of prayerful discernment. There's a lot of hurdles, right? Licensing, government approval in our contemporary culture, and so on. But what about you and me in terms of our personal choices, okay? I believe if we choose, which I believe is the appropriate decision, to never go against conscience, and that we should refuse to participate in actions or deeds that counter personal values. How do we do this? Well, as I see it, there's three options: to continue practicing and face the music, to take an oath, or to redefine your clinical practice. So some people may be called to continue practicing according to their convictions, and that they provide comprehensive information in a caring, respectful manner so that patients are aware of options and your recommendations to them, to respectfully decline to fill requests in situations of ethical collision, and to face potential consequences with conviction, and to engage the authorities as required. And for those that choose this, I really recommend using the medical literature and science to support your position, because God's laws on morality are also God's laws on science. He is the same author, and good decisions morally are also good decisions from a scientific point of view. And so I really suggest that one uses the science. We talked about one of those with regards to birth control yesterday, that there's a lot of science to support what we're doing, right? The second option, potentially as a defensive strategy, is to take a Hippocratic Oath, something that many people here will be doing tomorrow. Okay? It says in the oath, we're unable to carry out procedures that induce death and unable to refer for counts for procedures that induce death, right? Now, are the regulatory bodies explicitly demanding that physicians break their sworn oath that was the bedrock of medical ethics throughout the history of medicine? Arguably, then, are regulatory bodies compelling their professionals to engage in a breach of trust? Right? If so, what's the meaning of an oath? I mean, MPs take oaths. So is it willy-nilly? Do they mean nothing? Right? So perhaps taking an oath may have some impact. The third, then, is to redefine your clinical practice. For some, that will mean transitioning out, to retire, to retrain, to go to law school, to move to another jurisdiction, like another province where this is not going on yet, to limit your practice, for example, not to accept new patients, no walk-ins, or to transition to a lower risk field to become an OR assistant, or to do sleep medicine or sports medicine, where these kind of issues are usually not as prominent. Is there anything wrong with avoidance? I don't think so. I think people have to seek the Lord and see where He would have us be. But there are consequences, right? I mean, people leave, of course, you leave your patients and your practices that you're committed to. And also, if there's no alternate representation in target specialties like OB-GYN, then all the policies in the field are going to represent perspectives that don't represent us. So there are consequences, right? Okay. In conclusion, my friends, the battle over conscience rights, as I see it, is part of the struggle now between the way of life and the way of death, and that we have the privilege and honor to represent the Lord in furthering the way of life. Although much good remains, contemporary healthcare has increasingly become a vehicle to facilitate the wrong way, sadly. This is a time of transition for us, an important time, and our choices are: personal and collective surrender has profound implications. I don't recommend it. I believe in support in efforts to rewrite the ship, and I believe that individuals must prayerfully consider options. In the workshop that I'm going to be doing, I'm going to talk about one option in more detail for those that might be interested. Thank you so very much for listening today.